Good morning, everyone. I welcome to you to New York, Mount Sinai, for our Happy New Year 2019 peripheral intervention cases. I, Vishal Kapoor, with my partner Sandeep Singla,
Morning, everyone.
would like to say good morning. And before we head up to the cath lab, I would like just to say that in case you have to see these cases or any archived cases from the past, you can log on to our website, ccslivecases.org. You can view this live case by the end of this week or any live cases from our previous sessions in the archive section. And before we head to the lab, just wanted to say good morning, PK.
Michelle, how are you? And Happy New Year to everyone. It's really a pleasure to welcome you back to Mount Sinai for 2019. We've done a tremendous year of live cases last year, and we're continuing our collaboration with a multidisciplinary approach for the last 4 or 5 live cases, and we continue that this time. But let me introduce our team, who you know very well. We have Ray Lascano, who's our endovascular nurse practitioner to my left, Asma Khalik, our endovascular fellow to my right. But today we have really two guests who are really dear friends of ours and really are going to help a lot with this case. We have Atul Kukar, who's the director of cardiology at Mount Sinai Queens, which is our sister hospital. And then we have thrilled to have Dr. Pablo Kim, who's the assistant professor of surgery, who's here to really help us understand this case, from all different aspects and how we as endovascular specialists to look at the case as a whole and what are the different treatment options in these type of cases. And we have a very interesting case for you today. So we'll get started without further ado to go to Asma to present the case. Asma?
Hello and good morning. So we have a 68-year-old patient, 8-year-old male essentially, with hypertension, hyperlipidemia, diabetes, TIA, prior history of prostate cancer, anemia, CAD with prior CABG in 2011, multiple PCIs following that, as well as sick sinus syndrome, who had a pacemaker put in the past, and it got infected, so that had to be taken out within the last year, Dr. Kukar?
4.5 months ago.
4.5 months ago, okay. Yeah, and then subsequently ended up, getting a leadless pacemaker recently, given that he had ESRD. So carotid stenosis as well, and significant history of PAD with prior PTAs. So he has been recently complaining of bilateral claudication symptoms, but more so right-sided buttock claudication, which is pretty significant, basically limiting him to 1 or 2 blocks is what he can do activity without getting pain. So his ABIs were 0.82 on the right and 0.87 on the left. His medications are, his usual diabetes medications, aspirin, Plavix, atorvastatin, and amlodipine. His hemoglobin was 10, creatinine 1. Next. This is a picture of his abdominal aortogram, iliac angiogram, DSA, and as you can see, there's a stenotic area in the right common iliac, which is about 70 to 80% stenosis, and also there is a saccular aneurysm right at the proximal edge of that prior iliac stent, which per se appears to be open. And this was put in 2015, right? Yeah. Next. So this is just a cross-sectional imaging of that we did after that angiogram to get an idea about the sizing and the reference diameter. So this is the common iliac beyond the aneurysmal segment, just to give an idea of what the reference size is. It measured to be 7.8 millimeters, and the iliac stent that was put was a 7.0 iliac stent. Next. So and this is just sorry, I forgot to use a pointer there, but this is just right after the iliac bifurcation. This is to demonstrate the aneurysmal segment, and there's some thrombus layering the wall as well.
So
next. Yeah.
So let's stop there, and I want to just show the angiogram, and then I really want to get Dr. Kim's opinion. So Dr. Kim, we had done an iliac shot here, and you can see there's an area of stenosis. And we, Dr. Kim, I don't know if he saw it, but we reviewed the old angiogram we were able to obtain the old discs. and there was no dissection, there was no trauma of any sort to that particular area which you're looking at in the common iliac artery. Plus, Dr. Kukar, you followed the patient. He became symptomatic over the last year, right?
Yeah, it's about a year ago he became symptomatic, and everything was delayed due to this infected pacemaker. So we wanted to deal with that first, and then we brought him in for the angiogram, which was done last week.
So this is interesting, Dr. Pablo, because he has developed this aneurysm, which we're assuming what kind of correlates with when he became symptomatic, and at that time he had an infected pacemaker, which was explanted. So anyway, you can see here that there is a stenosis, and then there's an aneurysm. The stenosis is not all that impressive, but the aneurysm certainly is. And then if you look at the runoff, there's a couple of other pictures here just to show you the runoff he has. You can see the SFA is really just mild. It's not really going to cause much claudication for him. The popliteal has, again, maybe a 50%, 30 to 50% lesion. Again, I can't imagine that causing him any claudication at that level. As you can see, there's really nothing much. And below knee, he's got severe disease because of his ESRD and diabetes. But again, that's not going to cause him claudication either. So, for both of us, I think we both felt that the aneurysm probably is contributing to his claudication and the depression of his ABIs. But Pablo, my question to you specifically is, in these type of questions, we obviously don't know if this is an infective etiology because we couldn't see a traumatic etiology. So, what are your thoughts on how we deal with this kind of situation?
Yeah. So, the first thing I see in this picture is a sacral aneurysm. And there's no really good studies studying the natural history of sacral aneurysm. But whenever I see this is not a patient that you want to wait on. I don't want to digress, but 6-7 years ago, we had a patient who comes in with a creatinine of 3, gets a non-con CT, and the resident tells me patient has a 3 centimeter aneurysm of the iliac. 3 centimeter aneurysm of the iliac. It should be repaired, but it can wait. The aneurysm is extended from the aorta to the iliac. So 3 centimeters was in the aorta, 2 point something in the iliac. We say wait. The patient ruptured a month later because it was a sacral aneurysm of the iliac, and we didn't scan her because the patient had chronic kidney disease. So you have to be very careful with this patient. These are not the fusiform aneurysm. These are sacral, where only one side of the arterial wall is weak, so they can rupture any time. So these are the cases that we see, and you fix it as soon as you can.
So go ahead. I'm sorry.
The next question is this patient infected or not? I'm hoping, looking at this picture, I'm hoping this is not infected. Obviously. Because treating this surgically will be challenging. If it's infected, obviously we shouldn't put a stent graft. We should fix it with an open procedure. Reaching this through a retroperitoneal incision will be challenging because it's very high. I'm not sure if I could control the proximal column from that area. It will require an abdominal and a retroperitoneal incision to fix this. So it would be a very challenging procedure, and unfortunately, just for this disease, patient may need aorta bifemoral bypass. That would be the safest solution. Some of us will try to do it through a retroperitoneal incision. So this would be a major surgery that the patient has to go through if it's infected. How do we know it's infected? Well, you look at the most simple sign first. Is the patient has low-grade fever, has been having fever for a long time, has any systemic symptoms. What's the white count? Sometimes some of this patient can present with very little symptoms of infection. But a CAT scan may help. CAT scan can show a lot of inflammatory changes around that sacral aneurysm. Also, if you're very concerned and patient has been having low-grade fever for a long time, you could do a white blood cell TAC scan. So if all those things are negative, I know that this is not infected. And thank God we can proceed with an endovascular approach.
Atul, in this particular case, can you talk a little bit about the infection? I mean, what has been done for him? Because I think for the audience, it's very important what Dr. Kim is saying. As an endovascular specialist, especially a cardiologist, you might say, hey, I'm just going to drop a covered stent in, it's an aneurysm, I'm done. But the infected part of it is incredibly important, and it's important to know the history as to how this might have occurred. If you don't have a traumatic etiology or some sort of ruptured plaque, or the stent that was in a ulcerated plaque or something, that could have then progressed in its natural history of atherosclerosis to form an aneurysm. Here, you didn't have any of that, and it was important that we got the film. But the second part is, obviously, you want to make sure, Vishal, that there is absolutely no infection here. And I think that's why Atul's done such a great job.
So I'll add a little history. So he's been dealing with a pacemaker infection for over about 14 months. It was either the pacemaker or the graft. ID has been seeing him. Eventually, due to recurrent bacteremia, they decided that they would treat him with antibiotics per dialysis session. After about 6 months, I've known him for about a decade now. We had a long talk about lifelong antibiotics, which was an option, or explanting his pacemaker, which everyone felt was the nidus of the infection. And he chose to say, I don't want lifelong antibiotics, let's explant. So he was explanted about 4.5 months ago successfully. He completed 6 weeks of IV antibiotics post-explant with repeated blood cultures being negative, no fever, no white count, and evaluated by both ID as well as the CT surgeon that explanted the pacemaker. So from a point of infection presently, we would say confidently there's no infection presently, at least and no systemic signs of infection right now.
And what happened with his pacemaker? You could maybe tell the audience.
So he had the pacemaker explanted. He was not pacemaker dependent initially. Last week when we did the angiogram, when we found this, I called PK up and we thought that we should do a CAT scan to see whether it's feeding by something else to be a little safe and get a little more detail of the aneurysm. After the angiogram, he went into junctional escape rhythm, hypotension. We temporarily paced him. EP felt he was okay based on his telemetry 48 hours. He went home, and about 7 or 8 days later, while we were planning to have him brought back here, he fainted twice. Went to the hospital, had his, he has a link, an implantable loop recorder, which was interrogated, which showed prolonged asystole. He was transferred back to Mount Sinai and felt best to put a leadless pacemaker in, which was placed, I think, Friday evening. So now he's hemodynamically stable, his rhythm is stable, so he's doing much better clinically from that point of view. And we went with the leadless pacemaker because of the prior infections.
And also, you wouldn't have put it in if he was infected at this stage.
Correct.
Right. So I think that's for Dr. Kim's point. Like I think and the CAT scan showed not much inflammatory changes around. And I think the audience has to understand, like, this is important. Like, you look at this and you see a stenosis, you see an aneurysm, and you say, let's just fix it. We're right there. But you see the thought process that you need to have. You need to have experts tell you, what are the different approaches, and I think that's important. Let's show the IVUS before we go to some of the management options.
PK, let me just dial back a little bit. I know
Yep.
we're going to talk about the technical aspects of the intervention. Just from a clinical perspective, Dr. Kim, what is your criteria or cutoff saying, okay, it's a 1 centimeter aneurysm, a 2 centimeter, a 4? What's your cutoff saying above this or at a certain growth rate should we intervene versus just observe? I know you told us the history of one of the cases we had with rupture.
So
what's the criteria?
So, again, I want to make the clear distinction between fusiform aneurysm and a sacral aneurysm. Fusiform aneurysm will have a good multiple studies that shows that at 3 centimeter, when the common iliac artery exceeds 3 centimeter, that's when a patient requires an endovascular and open approach. But on sacral aneurysm, unfortunately, we don't have good data, for obvious reason, because these cases are not that common. So I think a lot of endovasculars or surgical specialists will agree that if anything sizable, anything that looks like over 2 to 3 centimeter on a sacral aneurysm will fix it. It's definitely here in the common iliac, but on the aorta, a sacral aneurysm that measures 2.5 to 3. I don't have any doubt that everybody in this country would fix that. A sacral aneurysm, not a fusiform aneurysm.
So what about in the rate of progression, Pablo, Dr. Kim? Because, this guy, obviously, in the last year, this has happened. And prior to, he was asymptomatic, maybe it was smaller, this clearly has progressed. And now he's symptomatic. I mean, in terms of, okay, the rate of progression, is there something to do if you're considering an infective etiology versus an atherosclerotic etiology?
Well, if it's infected, it has to be fixed. I think these are my three choices. If it's infected, it has to be fixed right away. If it's sacral, I'll be too nervous to observe and see if it gets grown, because they're gonna rupture sooner or later.
Sure.
So infected sacral like this, fix it. If it's more of a aneurysm degeneration that we see in the elderly population, then you can watch it.
Okay.
But again, just an outputching on one side of the wall of the artery, not a aneurysm that includes all 3 layers of the artery, is something that you have to fix. One side is only weak. You never know. Maybe he has a little bit of adventitia. He's ready to burst.
So do iliac aneurysms behave like aortic aneurysm? Can they have feeder vessels? Can they have where you have to worry about endoleaks and things like that in these type of aneurysms?
Iliac aneurysm has less. They don't have all the lumbar artery. They have less type 2 endoleaks. The only thing you really have to worry about is the internal or the hypogastric artery.
Right.
Which fortunately now we have so many technology to tackle this. Even 2 years ago we were building up snorkels, and we have all this a biobond graft and all this other endovascular technique to do that, but now we have an approved IVE device, a branch device to tackle this. So the main thing we're concerned here would be the hypogastric artery.
And you'd also worry about the landing zone, get a seal proximally and a seal distally without involving the hypogastric. That would be the goal.
Well, this case, looking at the
It's
picture,
ideal, yeah.
is just you just. Dr. Kushner, you picked the perfect case with Dr. Kukar.
Yep.
But normally, yes, you'll be looking at the proximal and distal landing. So you make sure that, so the proximal is not a problem. We can always make it into an aortoiliac case, and you could build up. The major thing I would concern about an iliac case would be the distal landing zone. And the numbers I go by would be about 25 would be pushing it. You could flare at 25, and if you have the size of the vessel is 25 maximum, and you have at least a 1 centimeter landing zone, you could probably get by without covering the hypogastric. I think the biggest limb is a ovation limb, which is 28. Most of the other limbs are 27. So you could, if you put an ovation, you could probably cover at 25. But if you have to go past the hypogastric, I don't want to digress. We have options to do that, and we can talk about the different options.
I think Asma has prepared something very nice.
Yeah.
Why don't we go to that, because obviously the case itself is really the discussion, and we want to talk about the IVUS before we get to it, and we have Dr. Kim here to really go over some of the stuff that Asma is going to show. Asma, can you talk about the different types of management, what the guidelines tell us?
Yes, so the strategy I guess so thanks. So just a little bit of review about what we just talked about. So the common iliac artery aneurysms are associated with a AAA in a majority of the cases, like 75% of the cases. They are they are concomitant with the AAA. The isolated common iliac artery aneurysms are less common, and majority of the times they involve just the common iliac artery and don't extend beyond. Both right and left side involvement is equally noted, and 30% of the times they can be bilateral. Per se, the external iliac artery aneurysms are found to be rare. Next. So this is just a interesting slide, and it's from it's basically the Society of Vascular Surgery, which gives us the normal diameters and what they consider aneurysmal in males and females. So in the common iliac artery, they're saying that 0.97 to 1 centimeter is considered normal. So in the females, plus minus some, with some margin of 0.15, and if it's more than 1.5 times that diameter, then it's considered aneurysmal. In the males, it is the normal diameters are 1.1 to 1.2 centimeters, and then if it's more than 1.7 times, then it's considered aneurysmal. And those are the internal iliac diameters are usually around the order of 0.54. Next. So this is what we were talking about before, that the rate of growth and how it's related to the progression. So usually the aneurysms, just like Dr. Kim pointed out, that if it's a less than 3 centimeter aneurysms, those, as we know from Laplace's principle in physics, that those will tend to grow less, especially if they are fusiform. They just, probably the rate of growth is about 1 millimeter a year. But if they are 3 to 5 centimeter aneurysms, then you see the progression of growth, it increases dramatically. They increase by about 2 to 3 millimeters a year, which is why most of the guidelines will say to treat even the asymptomatic aneurysms that are above 3 centimeters, and especially like Dr. Kim said, if they are if they have an asymmetric rate of growth, meaning if they're saccular. Next. So this is some basically just the things to remember when we are trying to repair these aneurysms, be it endovascularly or surgically. So looking at the size of the native vessels, what the patient's age is, what clinically what the rate of growth is, associated pain, or for example in our case associated stenosis, and then the ease of repair, meaning whether it would be easier to tackle it endovascularly or surgically next. So this is, I don't know how well it translates, but this is a nice paper that tells us that they use this as a classification for based on the landing zones, proximal and distal landing zones. They have classified the aneurysms of the common iliac artery into type A, B, and C and D. So type A aneurysm is sort of like our aneurysm, which is confined to the common iliac artery and has good proximal and distal landing zones. So type B is are usually ones where there is a good proximal landing zone. However, the distal landing zone is not there because there's involvement of the of the internal iliac takeoff or of the internal iliac as well. And then type C is the ones in which there is a good distal landing zone. However, it involves aorta. So that means basically essentially less than 1 to 1.5 centimeter proximal landing zone. So in which case, like Dr. Kim was saying, then it gets converted into an aortic case. So we may use a bifurcated stent graft for those kind of cases. Then so type D is, I guess these are the they're essentially unsuitable for endovascular repair in the sense that they have neither a proximal nor this distal landing zone. And next, please. Yeah, so like I said, ours is a type A. Next. So this is a little bit of an algorithm. I'll go into details of it, but this I found was a simplified version of it. So essentially, if we notice it on imaging, if we notice an internal, an iliac artery aneurysm in imaging, the first question to ask is whether there are symptoms. So, meaning abdominal pain, pelvic pain, claudication, or thromboembolic event. If that's the case, then then that would make the case to repair that aneurysm, be it endovascularly or surgically. And if it's associated with the AAA as well, then that would make a case for repair as well. However, if the patient is asymptomatic with a coexistent, again, like I said, if it's associated with in the setting of a AAA and there's a coexistent iliac artery aneurysm, and which would also make a case to extend the grafts. If it was more than 3 centimeters, then we can make a case to repair it as well. If none of that is true, then they say that if it's, let's say if it's an asymptomatic aneurysm and the diameter is less than 3 centimeters, then especially if there is a uniform expansion, then it would be okay to just serially image it with most likely with an axial imaging like a CT scan, just to see the rate of growth. So and it varies between the European and American guidelines. So it looks like some are so more than 3 they're recommending like annual screening if it's more than 3 and asymptomatic. So again, so if it's more than 3 and there is no evidence of expansion, then they essentially just serial imaging and just clinical observation is what they recommend. However, if it's expanding at a quicker rate, like we said, if it was expanding more than 2 to 3 millimeters a year, then that also would make a case for earlier repair of the aneurysms. And next. So this is a very busy chart, but this is from basically the Rutherford's textbook, and I thought this was a very exhaustive way how to manage these based on the classification we just talked about. So the type A, which is what we are dealing with here, is essentially based on the landing zones that there's a good proximal and distal landing zone, and both are in the common iliac artery. So essentially they say that we could just use a covered stent, either balloon or self-expandable, and just exclude the direct exclusion of the aneurysm endovascularly. However, type B, in which we just talked about, and if there's a good proximal landing zone without there being a distal landing zone, meaning you have to deal with the internal iliac artery. So then there's a couple of then they divide this into whether we can do it anatomically or extra anatomic with preservation of the internal iliac artery, or if you want to sacrifice the internal iliac artery. And I can go in, I'll read with you guys the details of those. So essentially what they're saying is that if the internal iliac diameter is less than 15 millimeters, then it's possible to have do it anatomically with internal iliac preservation with the devices, as Dr. Kim just mentioned. Now we have iliac IBDs, iliac branch devices, which can essentially be used to cover the stent into the internal iliac artery. However, if the diameter of the internal iliac it's 20 or more millimeters, of non-aneurysmal tissue, then I guess we are limited by the size of these IBDs.
We can discuss this a little bit. I mean,
Okay.
this is a great presentation, but when
Can you go live on Dr. Kim, guys?
Yeah.
there's a lot of
can
things
go back to it.
that is different from a textbook and the pragmatic way approaching this. So sure, there's a size of internal iliac artery that you should be concerned because some of these devices cannot cover. I think I believe it's 15 or 16. However, you could always find a spot in the internal iliac artery that is not aneurysmal that you can place. So a lot of times we have used one or two of the IV branch graft, but if you can, we can also bring a BBX and try to go further down and
I
try
see.
to get a seal. So those rules are not always set in stone.
I see.
There's things that you can do, and we don't want to go too outside of the IFU, but we know that a lot of cases we do to bring the best therapy to the patient.
Absolutely.
So just because you have a larger internal iliac size or aneurysm, that doesn't exclude you completely from the IVE device.
Got it.
You can really modify, so you can try to fit all those patients in.
Got it.
The other thing that I would take away from this great presentation is that, sure, there's a 3 centimeter common iliac artery aneurysm patient that comes to your office, and you can observe this patient. But the natural history progression of common iliac artery aneurysm is not as clear as the aortic aneurysm. The aortic aneurysm, we have so many trials really showing us the natural history that at 3 centimeter nobody rupture. Usually they don't progress to 5 centimeter. At 4 centimeter, you're gonna either scan or most people do ultrasound at 6 months, because at 4 centimeter, the natural history that in 5 years, most of this patient reaches 5.5 and they have to be repaired. We don't have those kind of robust study on the common iliac artery. So a lot of these patients, sure, if they have 2 and 2.5, you observe them every year and make sure they are not progressing. But at 3 centimeter, a lot of vascular surgeon or vascular specialist will fix this aneurysm, because following this patient and really measuring 2 to 3 millimeter on a CAT scan or ultrasound is not that easy.
No.
You move it this way and you can change the angle. So if it's at 3 centimeter, that's when I would start engaging the patient in a risk and benefit conversation, and we'll start fixing them. Obviously, at 3.54 is not a question, but at 3 centimeter is when pragmatically or more practically most endovascular specialists will fix these patients.
Okay, great.
So one question before you finish.
Yes.
There's so much emphasis on internal iliac artery preservation. And, as you know, you do a lot of aneurysms. You guys coil the internal iliac artery, used to, a lot of times, if you have the ipsilateral that's open or
Yes.
contralateral that's open.
Yes.
So why are we spending so much time on internal iliac arteries, and
Yes.
are they that important from a
So-
cardiology perspective?
Yes, so I'm going to digress a little bit and describe how wonderful this institution is. We have our chairman, Dr. Mike Marin, who is the father of endovascular aortic repair. Thanks to him, we have thousands of cases. So we have one of the biggest series of hypogastric embolization in this institution. We have over hundreds of patients with unilateral hypogastric artery embolization that have done very safely. When we do this embolization, we always stage the embolization
Yes.
procedure and the aortic or iliac endovascular procedure. It's very important to stage it because you want them to develop collaterals. The idea about not preserving hypogastric artery came from a trauma research, and it shows that if you occlude or you acutely ligate the hypogastric, patients do still okay because they are collaterals from the either hypogastric or they have collaterals from the profunda. So we have a big series of unilateral. We have over 30 patients with bilateral hypogastric embolization. They are all staged. We always do one embolization followed by another embolization. We put 2 weeks in between, and then we put 2 weeks for the last index procedure. Even for bilateral, if you stage it, we are able to do this very safely. We did not have any colonic ischemia complication or pelvic ischemia. You could have severe cases such as even necrosis of the skin of the pelvis. So we never had any major complication if you stage it, and this is the largest private experience in the country. Now, we do have patient with buttock claudication. So that's something that you have to discuss with the patient if you're going to embolize the hypogastric. The rate of buttock claudication is about 30 to 40%, depending on what paper you look at, and it can last after 6 months. Most people resolve after 6 months. Very few, less than 20% goes on to 1 year, but almost over 90% they are self-limiting. So you have to sit down with the patient, discuss that you may develop a little bit of buttock pain when you walk. Usually, last couple of months, your chances of developing that is about 40%, but it's self-limiting, and most people are okay with that.
Well, it's interesting because I know with Asma's presentation, they talk about an aortic unibody with a fem-fem and an ipsilateral external iliac to internal iliac, you graft to exclude the aneurysm. So they go to great lengths in Rutherford, at least in the textbook, to preserve the internal iliac artery. They don't really mention that they only do this for contralateral iliac occlusion, internal iliac artery occlusion. So it seems like their goal for all these patients is to preserve the internal iliac artery. Would that be a fair goal for us to have, at least when we start?
We were never scared to embolize the iliac if you stage it. That was our approach at Mount Sinai Hospital, at least on the Department of Division of Vascular Surgery. But if you can preserve it, you should always preserve it. The only case that you have to preserve are the cases where you're covering the entire aorta. So these are the cases for morphine disease, Ehlers-Danlos, or dissection cases that you have covered the whole thoracic. Then you're staging it and you're covering the infrarenal. Now you're taking most of the collateral to the spine. So if you're covering the hypogastric on top of that, your rate of spinal cord ischemia is extremely high. So those are the cases that you absolutely have to preserve the hypogastric. And in those cases, we have gone in the greatest length, either a extra anatomical bypass, such as you could do a fem-fem, AUI and a fem-fem, and sometimes we do a U-biobond, or sometimes you can do a common to internal iliac bypasses. But we have done everything is possible to preserve. But otherwise, if you don't have that kind of a challenge, you can embolize them very safely. The patients do very well.
Thank you. Want to finish up?
Yes. Could we go back to the
slides,
last
guys?
Thank you. So essentially we were at the B1 level still, and we just said, as Dr. Kim mentioned, the sizing is important, but not that much. Like, there's always ways around it. So we could still use IBDs, and even though the size may not be what they have mentioned there. So and then the other approach they mentioned is the extra anatomical with internal iliac preservation, and as we just mentioned in the discussion, is placement of a contralateral aortic unibody iliac graft in the non-aneurysmal side, and then doing and that way excluding the aneurysmal side, and this doing a fem-fem bypass to provide blood supply to the ipsilateral limb, and then an endograft deployment from a ipsilateral external to ipsilateral internal iliac. Also, then they're saying that if you have to sacrifice the internal iliac, which is also possible, but again they mentioned that either exclusion with a covered stent or preferably embolizing it, and then, as Dr. Kim mentioned, staging the procedure and placement of a covered stent across the common iliac aneurysm to the external iliac artery is also possible. Now, going to type C, where there is no proximal landing zone, essentially you just treat it like an aortic case, and you do bifurcated endografts, and that way cover the ipsilateral iliac, extend into the into the distal common iliac landing zone. And for these, would you most commonly use Endologic's device, or is that's not necessarily?
No. If you
Any
don't have a
device?
proximal, any device, you could
Any
make
device.
it into an aortoiliac disease case.
Okay.
And you look at the anatomy, and you pick the device that fits the best for the patient and the anatomy.
Okay. All right. Okay. And then that is maintaining the anatomical with this preservation of internal. However, if you're not able to do that, you can still do it extra anatomic with internal iliac preservation, which is basically, again, you would do the same thing. You would place aorto unibody graft on the contralateral side, and then again do a fem-fem bypass, and with endografting of the ipsilateral external to internal. And again, type Ds, which are kind of tricky, but with the newer devices, we can still treat them endovascularly, although they're not the most fun probably for you guys to treat. But they're saying that if the internal, again, as we mentioned before, proximally we would extend it. You would just treat it like an aortic case, and distally you would use IBDs, or do like a double barrel, or snorkeling, or whatever techniques the surgeons have in the armamentarium in order to preserve the iliacs. And again, extra anatomical, you can do the same. The same thing these guys do is basically place a unibody aortoiliac graft on the contralateral side, and then do a fem-fem bypass. Again, then they can bypass the external into the internal. That would prevent pelvic ischemia.
But Asma, I think that's important. I think, Pablo, like what you said, I think even though these are guidelines, we'll probably go to the next one, next slide here. I just want to conclude on this, which I think is important, is that with the newer equipment, with the VBX stents, with the Viabond stents and other covered stents companies, not to be exclusive to Gore, you guys can pretty much construct the body that you need in order to be able to. How often are you doing surgical revisions of these? Or surgical corrections of an aneurysm? Is it mostly endo that you're doing? Especially iliacs.
Yes, we're looking at where Mount Sinai, and here is, I don't remember the last time we did an open iliac case here.
Exactly.
And even aortic is 99% endo. And the technology is so superior, technology is so advanced, and we have the opportunity to offer the patient a much less invasive an approach with much less risk. So it's so much better for the patient. And we're just lucky to be at Mount Sinai, where we do everything endo. If we need it to be open, we're here. We do it very rarely, but we definitely have couple cases. I have yet to do in iliac open case, because we do everything endo. Now with complications, we have done it. We have, as you know,
you have to do what you have to do.
We can get in there in 20 seconds. I just want to make a quick comment so that I don't want the audience to go out of here and think that in Mount Sinai we coil everybody. Now that we have an IV device, I mean the number of IV cases that we have done here is tremendous. And if you can preserve it, you should always preserve it.
No, that's
always
a take-home
preserve
message.
it. Yeah. Do not coil if you have to. We coiled a lot before because constructing a snorkel case is extremely hard, and sometimes can be very tricky. And sometimes you can preserve the internal and you lose the external. So that was the tricky part. But with the IVE, the device is so well designed, and it is very easy to use. We could preserve it. We always preserve it.
Got it. So Vishal, any comments before I play the IVUS? Sandeep?
No, it was a great presentation. Yeah, go ahead.
Yep. Sandeep, can you play the IVUS, Mike?
Yeah, excellent talk and excellent presentation, Asma. And I think the big point what Dr. Kim alluded to is that all this literature, the size is 3 centimeter, monitoring, then 3 to 4 centimeter, that applies to fusiform and not secular. So that is a big point. And I guess the way I kind of took it is that once you see a secular aneurysm, that you have to fix it once it is beyond 2 centimeters. Is that right, Dr. Kim?
That sounds very appropriate.
Yeah, I mean,
So you can see with the IVUS, we're going to start it again, Mike, for me, so we can show everybody. So you can see the IVUS starting from the aorta coming down. Go ahead, run it. And I wish we had done it with ChromaFlow because it would have definitely shown the flow inside the aneurysmal sac. But you can see that the aorta looks, pretty good. Nothing major there. And then as you come down into the common, you'll start to see quite stenotic region, which will then show well, we had ChromaFlow, which would have shown flow into the aneurysmal sac, which obviously we can't see, but you'll see there's the loss of a wall, which will clearly show very, very soon, which will then show probably the communication into the aneurysmal sac right around there.
that's the disease.
Right around there. You can see it's a heavily diseased vessel.
And then there it
And then
is.
that's probably the aneurysmal sac right there, and then
then
followed
comes
by a true wall coming right there. So I think, clearly this shows there's a lot of layered thrombus you can see at the level, and now you're inside the stent. And the stent, again, is well opposed to the wall, doesn't really have much intimal hyperplasia. And, so this is kind of where we're at. So I think we have IVUS, we have other things showing this, and I think we're going to treat. Did we size this, guys, properly by CAT scan? Was what, 7?
It looked like 7.8.
7.8. So Dr. Kim, we're on, right now we have a 7-French system. We did an IVUS. We have a contralateral 4 just to image for purposes of teaching. You don't need to do that, as you know very well, but just for teaching we did that. And at this stage we have a very stiff wire, not a Lunderquist. We have a supercore wire up into the descending aorta. And our plan was to direct stent this with a Viabond. With a Gore VBX. Which is, I believe, the stent, and we chose a 7 by 39, right? 50. We have 7 by 39 or 59. So I think we're going to just take a look here and decide what size we need, and then we can do it together. This is the easiest part of what we're doing, but at the same time, I think technically we need to be careful in terms of how we place this.
So I have a question.
Yes.
PK or Dr. So is there any benefit to like slightly oversizing in this case? Like, if it's a 7.8 vessel, like going to the next size, like 8 instead of 7, or?
Well, this is a balloon expendable
So
stent.
we can just crank it up?
Yes.
Okay.
So the beauty, as you know, maybe you could talk about the VBX and the nice things about the VBX for the audience.
Yeah. So the really good thing about the BBX is an extremely flexible stent, but it's a balloon expendable stent that you can always, a 7 can go up to, if I'm not wrong, up to 13. You can blow it up to 11 or 13 depending on what kind of 7. 11. You can go up to 11. So you don't. It's not like a self-contained stent that you oversize by 1 centimeter. So you can always blow it up. So I would just look at the size of the vessel and select that, and then when you balloon it, you can always over balloon a little bit.
Also, the IVUS was very useful. Play it again, Mike. It's very important because the IVUS helped you to identify at least where you think the aneurysm is. Can you just scroll down, Mike, for me a little bit? As you see at the proximal edge of the stent is where you see the drop off of the wall, and you can start to see the aneurysm kind of right around, a little more, right there. Right? And then as you come down further, you see the stent is starting right there. So when you size the stent, you know that you need to, how do you decide, Dr. Kim, in terms of how much proximal you need to get a proximal seal and how much distal you need to get a good distal seal? Or is
I always say 2 centimeter to be safe.
Yeah, 20
to be
millimeters.
safe.
Okay.
But it looks like we have great this time proximal landing zones.
So what we're going to do is we're thinking about putting a 40 millimeter stent, or would you go 60 here? Because, I mean, this is for cardiologists and everybody out there other than a surgeon who's doing, or if you're doing a lot of aneurysms, it's easy.
Yeah.
But for a person like myself, I'm a little worried about getting my seal, and that's what I want to talk to Dr. Kim.
So, there's a lot of, the hypergastric aorta is pretty far down. You could go with a 40 and a 60. The easiest way to do this, and eyeballing is always tricky because you think, oh, it's 40, but then you put the stent, and it's like, I need a 60. So you could put a marker pigtail.
Right.
And count the centimeters, and that would be the easiest.
So let's get a marker pigtail, Chief. Give me a marker pigtail. Because I think these tricks are very, very important. Or how about balloon occluding it and then, taking a picture?
The problem is you have a sacral aneurysm, so
Right.
God forbid.
God
so
forbid,
we
I
have a
agree.
little bit of an excitement here.
No, I told.
Bring up a good point. This is one of the discussions we had that this should be a direct stent case. There should be no pre-dilatation.
No need to especially with a BBX. There's no need to pre-dilate.
Right.
because-
Right.
Now, the question is, should we put a sheet all the way up? In a case like this, my preference would be put a sheet and then pull the sheet back.
Unmask it.
Yeah.
You know, that was more of a problem with the old atriums where they used to come off the thing. We've done a ton of VBX. We've never had a problem with them falling off. You know, so happy with that. And also, to be fair, Atrium also fixed that problem. So they don't have that problem anymore either. But we've had a couple of atriums that came off the balloon, and we used to fish them out. It was ridiculous when we were working with really, really tough iliacs. I think he's looking for the marker.
Dr. Kim, what do you think? So placing the stent through the stenosis in the setting of an aneurysm right there, would you feel that the
Get it to dilate.
pushing the stent past the
Dilate.
stenosis through the aneurysm is going to be more risky?
I don't think so. Again, that's why I was proposing the idea of putting a sheet.
We're gonna do that now.
When I do any gore case, even aortoiliac cases, we always put a sheet all the way up. There's some cases I do bareback, such as endurance cases, some of the other devices. But at gore, we always put a sheet through it. But in a case like this, and you know, the stenosis is maybe a 80% stenosis. I wouldn't be concerned about
No, I'm
putting
not
a stent
concerned
there.
here. So why don't we, because I think Damien is going crazy looking for everything. Why don't we just go ahead and do the stent? Give me the 40 millimeter, please. The Viabon. I mean, the VBX. Here we go.
Is there any disadvantage of pre-dilating that stent? I mean, I know it's not critical. You passed the sheet, so it's not that bad. But would it be wrong to pre-dilate it to create a better track and then put a stent in? Any flip side of doing a pre-dil on this associated aneurysm or no?
Well, there is. I think from what Dr. Kim had mentioned a little bit earlier, you know, you worry about embolization. It is an aneurysm. You know, anything could, and you saw layered thrombus on the IVUS. So that's one of the reasons I think good technique by doing a runoff picture is very, very important. Go put me on coronary, guys. I think also the other thing is also, God forbid, you rupture, you know, the aneurysmal segment with predilatation. That's a problem. Mag up a little, please.
You know, going back to the previous question, the only time I would be concerned about a stenosis on the iliac artery would be when I'm doing aortoiliac endovascular repairs and you have to pass multiple devices, like you said. That would be the only time I would be concerned about a stenotic
Ready
iliac.
for picture? So we're going to take a picture here, and then we decide. You can attach.
Go up a
It's not DSA,
Yeah,
it's
it's not
okay.
DSA.
Go ahead, inject. You could really see it, and it's actually proximal. You can see the connection proximal, Pablo. Look at proximal at the common iliac. You can see the leak right there. See that?
Yeah.
Yeah. So actually, we should be a little bit higher.
Yeah,
Yeah.
right there.
Yeah. Let's do another picture.
Mm-hmm.
Okay.
Yeah, that's
What do you think, Pablo?
I think we're getting the 2 centimeter distal landing zone.
I think we are, because there was no leak inside the stent.
Yeah.
If we need to put another one, we can use another one down there. You know, I would push it a little further, Dr. Singh.
Yeah, we
Yeah,
might,
if you need to put another one, I
might
would
be a little bit high. You know, you have to be careful
2
about
millimeters.
not gelling the other side.
Yeah, let's take a better picture here. One more. He's yeah, we're a little.
Yeah,
actually,
that's high, right?
That's
Because
a
you have
little
the
high.
That's a little
verification.
high.
So we can always pull back a little.
Yeah.
Right there.
That-
Little
Right
die.
there, right there.
Little die, Chief.
Yeah,
I kind of
that's
like that,
perfect.
Pablo. What do you
That's
think?
good.
Another marker down.
Maybe a touchdown, but you know, Dr. Krishna, you're the captain of the ship
No.
here.
I mean, to me,
Now-
I'm not worried about the contralateral side. I can tell you that.
Yeah.
So I'd be happy here. Let's go up
Yeah.
here. I'm actually.
Wait, even if you gel, even if you gel it would be an easy fix.
Exactly.
I
Yeah.
mean, the other
I'd
side
rather
is
seal
not
the
that
aneurysm, go.
diseased, so I don't
Why
think
not?
it should cause any much trauma anyway to the other side.
I'd much rather seal the aneurysm.
I'm at 6,
7.
7,
What's nominal, Mike?
12,
8,
7,
8, 9, 10, 11,
9, 9, 8, 10,
11,
11,
12.
12.
Little pain is good. Okay, down. Go up again.
10, 12.
12, down. Okay. So obviously for everybody at home, we have the aortic rescue kit. We have the large sheath. We have everything available to us. If God forbid we have an issue with this, so generally here I take a picture with the balloon. Let's go ahead, go to DSA. I'm watching my pressures. My pressures are rock solid. I have my balloon there, I have my sheet there. Don't worry, Damien, we got it. Go ahead. Very nice. So we got a seal there. So let's walk this out now. Now can you measure the common iliac for me, what it was on IVUS, guys? I want to see what the common iliac was and then decide if I need to post-dilate.
It was about 10.
It was about 10.
Yes.
Let's measure it anyway.
Measure.
Let's measure. Give me a 10 millimeter by 2 balloon, guys. So what is the shrinkage, Dr. Kim, in your experience with these VBX stents? Very little, right? From what I hear.
Very little, and even you look at the box and you use a smaller stand, you expand it to 13, and you think it's going to go from 50 something to 30, but they don't shrink as much.
They don't shrink as much.
So it's a little bit tricky sizing this sometimes.
That's the worry, and like you said, I wasn't as worried about the contralateral side because I had my sheath. I mean, I had my catheter up. I could put a wire up. If we need to bifurcate stent, we could stent it. And matter of fact, there looks like there is some disease on the other side too. But what I'm going to do is just touch up the proximal here. For those of you at home, we did a crazy iliac case yesterday for Link, and we used the barred live stream stents, and they were also very good, Dr. Kim, in terms of trackability, expansion. We had a completely occluded iliac. We had to use 2 live streams and an Abbott self-expanding, and it worked out really, really well. Again, very well through the 7 French sheath. So here I'm just, for everybody at home, I'm just going to hit the proximal edge. I think distally I'm okay. I'm just going to go up right here. Go up just slowly. And again, you don't want to go necessarily to 10. You want to go to profile. Put me on coronary, please. You want to just go to profile and really kind of smooth out the edge here. So we'll just go up. There you go. You can see there's a little indent to the stent there. So I just want to try
4.
to. What's nominal?
6.
Okay.
6 now.
5, 6.
That's what
Okay, 6 is plenty.
I think this is very important because it's an aneurysm case, and you want to prevent an endoleak.
Exactly. You got to get that seal.
Down.
Okay, down. I'm going to pull back a little bit. We're going to go up again. Go up here.
Now, Dr. Kim, how would you follow him after this? Would you just clinical follow-up, or would you do a CAT scan to look for a leak?
That's a very good question. And the first year, I'll probably follow with a CAT scan, make sure there's absolutely no endo. Definitely a month after the case, I'll get a CAT scan. It's hard to, even though if you go to a good lab, you can visualize endoleak, but I'll get a CAT scan to make sure. Maybe 1 or 2 CAT scan in the first month and 6 months. If there's absolutely no endoleak, you can follow with ultrasounds.
Okay.
Let's do a bilateral injection here. Somebody inject through put me on DSA, Asma. So we're going to do a last picture. I know Dr. Kim has an OR case, so we're going to let him go, and I'm going to do a quick IVUS and then make sure that there's nothing going on from our end. But from our end, I really want to thank Dr. Kim for really giving of his time. I mean, it's really a big deal to us that you showed Dr. Kim. Thank you so much for helping us with this case. I know the audience greatly appreciates it, but we'll do an IVUS very quickly. Can I have an IVUS catheter? Give me an 014 wire. We're just going to do here an IVUS, Dr. Kim, just to make sure that we have good apposition proximally from the aorta as we come into the common. And I think it's important, and the IVUS is probably very undersized. I just want to change the wire. IVUS with a regular, or just using the dilator to change the wire. Give me an 014 wire.
Okay. This is the 018 they have.
That's fine. Put an 018 through this.
IVUS.
Yep, you can pull this out. Give me the 018 wire.
Yeah.
So I just want to make sure, just to make sure that we have a good apposition get a good proximal seal zone and a good distal seal zone. I think this will really help us to see how we are in terms of our seal zones in order to make sure that this is, we've done a good job, and I'm trying to be smart and I can't get the IVUS in here. So. Nope, no, right? Can I get a wire introducer, guys?
we need somebody younger like Ray
Nope.
to pitch in.
Thank you.
Thank you.
Thank you very much.
Thank you. Perfect. Okay, senor. There you go. There goes the IVUS. So quickly, let's load the IVUS when Dr. Kim is still here. So Pablo, in the ultrasound versus CAT scan follow-up.
Yes.
I know you spoke ultrasound.
So for
I mean,
aortic disease is very clear. I do a CAT scan at 1 year, 1 month, 6 months, then a year, and every year, if there's no endoleak after 3 years, we do ultrasound after that.
got it. So for 3 years, you do CAT scans.
Yes, for aortic disease.
Got it.
If there's an endoleak, you have to do 1 year CAT scan every year. If the aneurysm is growing, I'll do it a little bit sooner. And that's sort of a surveillance criteria that a lot of people will follow.
Okay.
For the iliac, you know, there's not much endoleak. So
Got it.
I'll do 1 or 2 CAT scans. There's no endoleak, ultrasound.
No Moss
Yeah.
radiation, right?
Yes.
All right, let's
Especially
go.
in a case like this.
Let's go with ChromoFlow. Thank you. So ChromoFlow is on for the audience, and you can see here. What I want you to look for is your eyes have to know before your mind. Your mind has to know before your eyes can see it, right? So what I'm looking for is the proximal seal. So I want to make sure proximally I'm sealed, okay? And this is the area right here, and looks like we are, huh? Looks like we are sealed to the iliac there,
Yep.
because that's the aorta and that's the iliac. So we're sealed proximally, right? And as we come down, I'm looking for any leaks around the stent, which I don't have, right? I'm keep coming down, and that's the area where I tried to post dilate, but again, very well expanded stent. And then now I'm going looking for a distal seal, and definitely there's my that's important. See, there's my covered stent, there's my regular stent, and there's nothing outside. You see that, guys and girls? So that's very, very important. All right, so I think with that, we're going to call it a day. Again, I want to thank Asma for a great presentation. I learned as much as anyone in the audience. And Dr. Kim, thank you again for your time.
Thank you
So
for
we're going to
inviting
do
me.
final runoffs to the audience, and I think this is a great example of a case that could look simple, but had the nuances that we have to look into. You need the multidisciplinary advice and effort in order to take good care of your patients. I'd like to thank Dr. Kukar for giving us this wonderful case to demonstrate to you guys, and we'll see you again next month. Thanks again, Vishal. Thanks.
Thank you, PK, for a great presentation and an excellent case for the new year. Thank you, everyone, for the audience, whoever joined us. If you have any questions or concerns, you can you can email us at and go onto our website, ccclivecases.org. You can view this case and previous cases on the archive section under the peripheral tag. Our next case will be on February 27th, 8 o'clock Eastern Standard Time here from Mount Sinai. Till then, both me and Sandeep have a great week ahead. Thank you.
Thank you.